So I am crazy about the fact that this medication should be used for health alone, and health can, for many people, look like weight loss, but this should not be about skinny. And so much of the narrative around this drug, I think, is focused on the skinny aspect. And you really have to actually be careful that we're not doing it for that reason and that our goals are to maintain health.
Hi, I'm Dr. Vonda Wright, and this is Hot for Your Health. Join us for conversations on the bleeding edge of science, health, and culture as we bring you tech innovators, thought leaders, and the movers and shakers who are transforming science fiction into your new health reality. Hi, everyone. It's Dr. Vonda Wright, and I'm so glad that you're back with us on Hot for Your Health, where today I am interviewing Dr. Alexandra Sowa. She is an internal medicine doctor, board certified in both internal medicine and obesity medicine. She is an entrepreneur and the author of the Ozempic Revolution, which has been out a few months now, where she really breaks down this amazing phenomenon that's happening in the country that has actually been around for 30 years. So
Exactly.
Dr. Sowa, thank you for joining us today and educating us all about metabolic health in general and about the GLP-1s in specific.
Thank you. Yes, I have been practicing obesity medicine for over 10 years exclusively. And so I was probably one of the first and early adopters of writing GLP-1s. And it was fascinating to me in the last few years as everyone has started to become very interested in them and people were getting prescriptions at their doctors. They were hitting a lot of roadblocks. And I thought, okay, I need to take everything I know about these medications and how I've made my patients successful and put it into a book. And so it's not only an exploration of the history of GLP-1 medications, how they work, how they're good for our health, but how you can thrive on them. In the traditional doctor's office, we just don't have a lot of time to walk people through the important lifestyle foundations. And so I laid it all out for people in the Ozempic Revolution.
Well, I'd like to start way back, actually.
Yeah.
We'll get to the prescription of these peptides. But the fact of the matter is, people don't realize that GLP-1 is a naturally occurring peptide in our body. So
Exactly.
why don't you explain, assume my audience knows nothing, which
Yes.
they will know because they're brilliant. But what is it? Where is it made? What stimulates it to be made? And can't
Right.
we make enough of it ourselves?
Yeah, great questions. Okay, so GLP-1 or glucagon-like peptide 1 is a naturally occurring hormone in the body, and it's one of the main hunger and fullness and fat storage hormones that affects our metabolism. And we make it naturally in our gut, and we have receptors everywhere, from our brain to our heart to our bone, everywhere. And this is actually why we see such big implications on this medication on our overall health. So how does it work? It works, I call them three superpowers. One on the brain, one at the level of the gut, and one at the level of the pancreas. So when it talks to the brain, there's a profound effect of these medications that says, you don't have to think about food. We're going to turn off your food noise, which is actually not a scientific term, but a term coined on the internet, but it describes it perfectly. People just don't obsess about food. And it gives them pause and an ability to just take a breath and think about what they're going to eat for their next meal rather than obsess about it. And then it works at the level of the gut. At the level of the gut, it slows down our stomach emptying time and our motility. Now, this is actually where a lot of the side effects you hear about these drugs, the nausea, constipation, diarrhea, comes from. But it also is how it affects our brain again and our body's hunger signals that say, look, you can put a pause. The food's going to sit here a little longer. And we're positively going to impact the hormonal pathway. And then finally, the way that's probably the most important way that it works for our health is it works at the level of the pancreas. And it makes our body very, very sensitive to insulin, the hormone that grabs up blood sugar, keeps our blood sugar stable, and takes it off to the rest of the body for its use in all of our organs. And this effect really reduces overall inflammation and so much of the damage that comes along with chronic disease. So if we can keep our blood sugar lower, not only does it help us tap into our own fat stores and lose weight, but it reduces overall inflammation. So those are the three big pathways. The thing that you said, which was so insightful, which was we do make this. So what happens? Well, I always explain to people that weight is not about willpower, and it's not as simple as excess calories or calories in, calories out. When your body puts on fat, our hormones become dysregulated. And I argue that excess fat is really neurohormonal dysregulation.
Mm.
And so our hormones, even though we make them, they stop responding in the way that we want them to. So we've long talked about things like insulin resistance. That's a big driver of weight gain and disease. And our body still makes insulin, but our brain and our muscles and our organs and the way it works is just not responding. We become resistant to it. Same thing for the hormone leptin. Leptin is a hormone that is involved in satiety, and junk food and fat. It actually makes our brain very resistant to the signal of normal leptin. Same thing happens with GLP-1. So even though we make it natively in our gut, it has a very different effect. So you'll see all over people claiming that there are natural GLP-1 boosters. This is a great way to maintain a healthy weight from the get-go. Focus on fiber, focus on foods, focus on activities that keep your native GLP-1 active. The problem is when we start to put on weight, that native GLP-1 does very little for helping our body maintain neutrality, homeostasis. And so the peptide version, the synthetic version of a GLP-1, the medication, acts like that natural hormone, but is in the order of 1,000 times stronger. The big difference is natural GLP-1 degrades practically instantly, between seconds, maybe up to 2 minutes in your body. And the synthetic GLP-1 lasts for weeks. And that profound effect really makes it so that we eat less, lose weight, and gain health.
But it doesn't ever go back to solve the root cause. And the reason I'm asking that is because a few things. I was reading that because I'm a big proponent of people eating enough protein, in particular high quality proteins such as high leucine content. And high leucine content itself will stimulate the production of GLP-1 pathways as a natural stimulant. But I'm thinking all the way back, because if we're talking about this being a neurohormonal dysregulation,
right.
I think, we talk about adults all the time, but the fact of the matter is, if you're saying that this dysregulation turns obesity into a disease and something that's not easily, we're desensitized to our own GLP-1, then this is happening to children at 1 and 2 years old. And so I feel like for all parents listening or people who care about other people's children, it just adds to the argument that children will do what they see. And if they see hormonal dysregulation in their parents, or they won't recognize that that's what's going on. But if they live in an ecosystem where that is happening, it's not just about adults gaining weight. It's about a lifetime of hormonal dysregulation. Can you go backwards for me? And
I love that. Yes.
Because we're putting children on GLP-1s now, and it seems like we're not giving their bodies a chance to do what their bodies are designed to do.
So there are two different arguments here. I think there are two different conversations. One is that something discrete happened in 1980, where we went from a country that had a small portion of people who genetically fit in obesity criteria. I come from a family of people who really always carried excess weight well before ultra-processed food. I was part of that. My family was part of that 10%. And you look at those pictures on the beach from the 1972, and most people are very lean, right? Versus now. So what happened in 1980? Ultra-processed foods happened. And interestingly, the cigarette companies that started to get regulation turned their marketing money and dollars into buying up companies that created ultra-processed food. And instead of selling the addiction of cigarettes, they started selling us the addiction of ultra-processed food. And we can't ignore that. And we really do need to fight against that. And then our whole lives changed too, right? Cars became more common. We started to become more sedentary, televisions, just the way that we learned and interacted in the world. We started to get more comfortable, really. And we've had obesity rates rising every year until actually recently we had a small downtick, likely because of these medications. And in that time, people will say, well, genetics can't change that quickly. And they are correct. But what can change is epigenetics. And so even in a period of passing down the way that your genes are expressed from generation to generation, we are actually passing on the epigenetics of fatness. And so when we talk about family units, us reversing our obesity as adults does actually get passed down to our children in real time, both in the way that we teach them, but also in the way that we give our genetics forward. So a woman who undergoes bariatric surgery after she's had one child versus her next and loses significant weight, the second child will have a less of a risk of obesity in adulthood because her epigenetics changed in real time. It's really fascinating.
And I'm going to unpack that for 2 seconds, because if Dr. Sowa is talking about epigenetic changes, so we are given our DNA, but the way that each gene is expressed, the transcription of proteins is mostly behavior. So that's what you're talking about.
Exactly.
And what stays turned on in the case you gave in a woman who had one child, then bariatric surgery, changed her entire body metabolism, and therefore the genes that she's turning on, then gets pregnant, has another child. That child is inheriting a different set of action proteins, action.
Exactly.
That's what you're saying.
Exactly. It's so fascinating. So that's the part that I think people get wrong when they talk about, well, it's just us. It's all just us and what we've been eating over the past few years. No, there's something else that has happened. And so you are correct. Our best bet at reversing future generations of obesity is to really change our whole environment. And I argue in the book, actually, that the effect on epigenetics now in this 1 to 2 generations, if we harness that and then also get to the root, as you were saying, of what caused this in the first place and put our energies into improving our food system and changing our behaviors from the get-go, really, we have finally the real potential to stop this trend, this epidemic of weight gain and reverse it. And so I don't look at these medications working against that goal. I really look at them working toward it. And when it comes to families, I have so many women and men who have young children in the home. And what's fascinating is that their weight loss journey, they're not necessarily sharing openly with their children, but the way that they start fueling their bodies, the way that their taste buds want to shop at the grocery store, the way that they want to move their bodies, it all changes. And the trickle down effect is profound. And so it's without great effort. So I just had a patient last week being like, my gosh, I never liked broccoli, like in my whole life, or I never once craved protein, but it's actually what I want now. And so my kids are eating it because we're not making 3 different dinners and I actually like it. And so do they now.
Yeah.
So it can happen really fast and which is exciting.
That is exciting. And when GLP-1s, you've been doing it for a long time, but when they become so commonplace that nearly everybody coming to my office, even not just people you would stereotypically think, you've tried everything, I've known you a lot of years, the up and down, you finally found something that is helping you in a meaningful way. To a person, they said to me, because I would ask them, well, how do you think it's helping you the most? To a person, and I realize this is not scientific, they said, I'm not buzzing anymore about food.
Yeah.
It
of course.
works in their brain. And I didn't realize, because of my genetics, probably, that that was a problem. I didn't get it. That because before I became educated by my own patients, I might have said, well, when you're full, stop eating.
Right.
What's the deal? Right.
Right.
That is not the way everybody's brain works.
No.
Do you want to expand on that? Because I think this allows people to have a little bit of grace, like quit torturing yourself. There's this thing called whatever it's really called, brain buzz going on.
Yeah. I think that we can really thank not only our patients for helping to change the narrative in medicine, but actually social media. I think the way that people have so clearly been able to demonstrate that for so long, I thought this was a me problem.
Mm.
And then I went on this medication, and then not only look at my transformation, but then look at the things that I'm able to do that I was never able to get over the hump before. People
Mhm.
got very, it's not just buzziness about food in their brain, but it becomes very weight loss does not always come through exercise, right? Exercise is incredibly important.
It is, but you can never out exercise your food. When
Exactly.
when three Girl Scout cookies is 180 calories. I mean,
Exactly.
let's be honest. That's two
Right.
miles of hard labor, right?
Right.
Put it in perspective.
And so people just get so frustrated and hate themselves because they're like, well, I'm going to the gym and I'm doing things that everyone else seems to love and it seems to work for them. And we're on the same page about what kind of exercise we should be doing. But, a lot of patients for years would come to me and say, I go to SoulCycle 5 days a week and I'm sweating and I'm dead and I'm so tired. And the scale keeps going up, right? And they really start to hate that part of themselves because they can't figure out what's happening. So you go on a medication like this and you start losing for the first time. You feel well, inflammation is lowered. You're not constantly thinking about food. And so then you actually get to make really good food choices. So it's not about not eating.
But there's a safe way. And I think that it's really critical that you lay out how you do it in your clinics. And I know
Yeah.
you're building a business about how to do it the safe way because
Yes.
without the guidance of a clinician like you or other people, and you just get an injector off the internet,
Right.
no one's telling you about how to optimize this journey or maintain
Right.
lean muscle mass so you don't get in this cycle of metabolic haywire.
Right. So I am crazy about the fact that this medication should be used for health, health alone, and health can, for many people, look like weight loss, but this should not be about skinny. And so much of the narrative around this drug, I think, is focused on the skinny aspect. And you really have to actually be careful that we're not doing it for that reason and that our goals are to maintain health. So, just kind of the core of the structure of how I approach this is health first, and you've got to identify your why. If your why if you can't come up with three whys, two of them rooted in health, I'll sometimes allow a vanity one to slip through.
It's
But if
okay,
it's
we're human.
exactly, that's what I always say. I always say the same thing. But if you can only come up with a vanity and you're just doing this to get skinny, this is not for you. You will not be satisfied. This is not going to improve your life in any way, and it actually will be detrimental. So let's not do this. And then, for everyone coming to me, we can come up with these profound whys, right? My insulin resistance is creeping up. I don't want to become diabetic like my mother. I'm not moving. I can't do Dr. Wright's get off the floor challenge, right? I want to really avoid the fate of those who came before me, and I want to feel better. And then we're going to really embrace habit foundation. So in the book, I walk through the three foundations: habit foundations, food foundations, and then the mental foundations, which is the part that's often overlooked at the doctor's office. And when you think about starting these labs, something that's actually very overlooked in some of these online and just kind of even fly by night, or even doctors' offices that are well intentioned writing these medications, they're not looking at a full metabolic picture. So I really want people to get labs. Labs are a big part of this.
What labs?
Yes.
People are writing down right now. They're making a
Okay.
list. They're going to take it to their doctor. What labs?
Okay. I want you to get a basic metabolic panel. We're
Mhm.
specifically going to look at your kidneys and your fasting blood glucose. I
Yes.
just want to make sure everything looks good. Then
Yep.
we're going to look at your liver. Fat often hides out in the liver and can cause
Fatty
early
livers.
inflammation, fatty livers. And we want to know where you started because these medications will help improve that. And we want to know if there's anything we need to manage. We are going to look at your thyroid. We are going to look at your cholesterol panels. The things that people tend to focus on with cholesterol panels are the quote unquote bad LDL. But what I actually really care about is your HDL. I want to make sure it's high enough, and I want to know where your triglycerides are. These are
Yes.
often overlooked in a traditional primary care office, but they are two of the five components of something we call metabolic syndrome. And if you qualify for metabolic syndrome, which a large portion of our country does, it puts you at great long-term risk for health. So I just like to identify it because it's a huge win when we reverse it with these drugs. I also like to look at vitamins often. Vitamin D is often very depleted,
Mm,
and things like B12 and folic acid too at the start of this. And micronutrient wise, we want to make sure that we're really keeping up our food intake. So I want to watch those from the beginning if they're depleted.
mhm,
Sometimes I will order advanced cholesterol panel testing depending on your risk profile. I might get something called a calcium coronary artery score, which is a
mhm.
great screening tool for heart disease, especially if your labs indicate that should we be having a discussion about a statin, even though we're about to embark on a weight loss journey. And then if we're really being complete at the start of your journey, I'd probably like you to get a DEXA scan looking at body fat composition and depending on age and risk, your bone density.
Mhm.
So that to me will give a really nice picture of your metabolic health and make
Mm,
sure we're not missing anything. The amount of people who have DM'd me since I wrote this book saying, "Oh my God, I lost so much weight, but no one ever checked my labs at the beginning. I
yeah.
don't know if I had diabetes."
Mhm.
We don't want that. And the good news about these drugs is they're so safe, actually, that you really don't need to check labs. That's pretty amazing. There's nothing that no lab markers are going to get worse. They're only probably going to get better. But we really should know where we're starting so that we can be very
Agreed.
excited about our improvement.
Agreed. And it's an opportunity uh, to actually have a doctor encounter.
Yeah.
Right.
Yeah. Which is
Which is
hard to do these days.
a good thing. So then when you check the labs, you make
Yeah,
the shared decision making that
exactly.
that Ozempic or a GLP-1 is appropriate for your patient. Walk
Right.
us through briefly the onloading, the maintenance,
Yes.
and do you change doses with tolerance if that's
Yes. Okay. So one of the things that I really need people to do before they even start the drug is to start some of the core habit foundations. I really
mm,
like people to log things, not
mm,
calorie tracking, but like log what you're eating. Are you hungry? What are the circumstances? How are you feeling? And then let's start logging our activities so we know how to improve that.
mhm,
So that's a key foundation. And I actually ask people to do that before they start the drug because sometimes when you start the drug, you have no relationship to your hunger and you can't work backwards. So I like for people to check in there at the beginning.
mhm,
And then we are really going to focus on making sure that every meal you're getting 20 to 40 grams of protein. That's kind of just a general sweeping statement, but it covers most buckets. If you're starting at 0 grams of protein, which is kind of impossible to do, but let's say 5 per meal, we're going to start you at 20, and then we're going to work our way up from there.
mhm.
My way of eating is not about calorie counting, but it's about macros. And
Yes.
really, I just want you first, when you're on these medications, to get your protein in first. Because
Mhm,
often your stomach is like, I don't want to eat more. And your brain's like, I don't want to eat more. And it's the most important nutrient to keep up your muscles and to keep bone health and to keep actually weight loss going and make
mhm.
sure that we don't tank our basal metabolic rate.
Yeah.
And then in the book, I have lots more tips about exactly how to eat and how to get in fiber because it gets a little complicated when your stomach doesn't want a lot of bulk of fiber. So we have to make sure we still pay attention to that at the beginning. And then I'll have people really work on their brain. And part of the logging in my methodology is making sure we're keeping track of a lot of the negative thoughts that come up along the way with these drugs.
Interesting. Yeah.
So at the beginning, people are really excited. And then universally, I'll tell you about everyone gets to about their first 10 pounds down. And then I get all the panicked portal messages. And like, I just know this isn't going to work. It's
Oh,
going to stop working. It's always stopped working at this
yeah.
time for me when
Yeah.
I've done diets before.
Uh-huh.
And there's a lot of expectation management. One of the things that's really important is to know that we don't want to lose weight too fast. And
Yeah.
you need to know what that actually look like. So I make people calculate that with me in our visits. I'm like, okay, what is this going to look like? Because if you think it's going to look like Instagram, which is, a quick cut from like one picture to the next,
Yes.
that's not real life. That's going to take a whole year, right? And so we
Yeah.
don't want to lose more than about 1% of total body weight per week for our health. And that's normal. And for some people, that doesn't look like that much weight week over week, but month over month, and then month plus month,
That
it
sounds.
starts to add up, right?
Yes.
So, talking about titration, I think a lot of people suffer with side effects because the way some of these drugs were approved, like Wegovy. So just to take it back a step. So we have two classes of drugs. We have GLP-1 alones, and then we have the dual medications, which is the GLP-1 plus a GIP. So we call that tirzepatide, and semaglutide is just GLP-1. So with many of these drugs, like Wegovy, the weight loss version of the drug, it just says, okay, start at this dose and then every month go up. And that's how the FDA approved it, because in order to see big weight loss in the way that we want it to affect health, about 15% total body weight loss, that's what they did in the clinical trials. Now, in reality, many people don't need to go up every month. And in fact, if you're feeling side effects, so if you're feeling any, nausea, I tell people if they're really having any side effects more than once a week, we're not ready to go up. And if you're losing weight, we're not ready to go up. We're going to wait until you hit a real plateau, which is about no weight loss for 2 weeks until we go up. And so I think there's a lot of misunderstanding of what microdosing is. I often think people say, well, I'm microdosing. And really what they're doing is that they're just staying at some of the earlier doses of the medication. And I think that that is very appropriate. And we do need to change the drug directions, because for a doctor who's like not an obesity medicine doctor, hasn't been doing this for a while, they're going to say, well, I'm going to follow the path. And then I don't get to see my patients that often. So I'm just going to write them like 6 prescriptions. And then every month they're going to go fill it. And then I'll see them back at month 6. And then people are like, I am vomiting. I feel horrible. And really, this is not a no pain, no gain situation. We actually want you to feel great. So if you're feeling side effects, you have to go back to your doctor and refigure out your dose or treatment. And with tirzepatide, we actually have, it's a little funny. There are 6 steps of the medication, but there are only 3 therapeutic dosages that insurance considers, which sometimes people run into because they'll say, well, I'll do great on the baby dose, but insurance will say, well, we'll only cover the next dose up. And that's really annoying. And if you're running into that, you can DM me on Instagram and I'll tell you how to fight it, because it's so annoying. But not everyone needs the higher doses. On the flip side, if you need the higher dose, that's not a failure. Sometimes people kind of in their brains, they'll think, well, I'm doing better than my cousin, friend, neighbor, because I got to stay on the lower dose. Or on the flip, they'll be like, oh my God, my sister's on the starting dose. Why do I need the full dose? Yeah. It's just different biology and a different response.
Yes, exactly. This is precision medicine. This is not one size fits all. So you've talked about labs when you start. You've talked about developing habits, and one way to do that is logging. You've talked about starting at a dose, and your criteria for changing doses is not just time, it's response. It's response in terms of weight loss, response in terms of side effects. You've been very clear, thankfully, that you're a macro calculator, which means protein, carbs, and fat, and protein is queen. How do you help your patients? 2 questions. Maintain muscle mass besides protein. Critical. And number 2, clarify for me, because, bone is my focus for the next few months, whether we know there's a relationship between high adiposity and bone density. Talk to me about this category of drugs and bone density.
Right.
So muscle first, then bone.
Okay. So a lot of misconceptions on both fronts about what these drugs do to both muscle health and to bone health. A lot of negative headlines, a lot of fear mongering that GLP-1 medications waste your muscle. So if you go on these drugs, you're going to lose all your muscle. Well, the fact is, when you lose weight through any method, you're going to lose both muscle and fat. GLP-1 medications, and even more specifically, I'll say just the GLP-1s in general, you lose muscle at the rate that you do with calorie restriction alone. So it's no more.
It's not amplified.
No, not amplified. With the dual agonist, tirzepatide, there's actually an improvement in body composition. And in the pipeline, we have drugs that might be a little muscle sparing as we lose weight. So really favor the weight loss of fat rather than muscle. So as a whole, even if you did nothing, which we don't want you to do, it's not going to be detrimental. Now, the only time that I have we don't see this in my practice, but kind of anecdotally in the outside world is when people just stop eating. So they bypass that idea of protein and they're like, this is great. I am going to exist on no food and I'm going to call this a win. And that's not a win because you're not feeding your muscles.
Mhm.
So how do we avoid just any muscle loss? Well, we're going to have some, but what we really care about is the body composition, is the ratio between your muscle mass and your body fat when you get to your end and throughout the process. So a DEXA scan at the beginning or a body fat composition, or even just getting an at-home body composition scale will give us a rough estimate. And in the book, I actually lay out all of the validated at-home scales for body composition because it's really nice to know where you start. It can be super upsetting. I will put it out there. Most people have a much higher body fat composition than they could ever fathom, especially
Yes.
women.
Yes.
And it's okay.
And I'm going to own that because I do this for my patients. And when they see the number 51% fat,
Yes.
which is not atypical,
Right.
it's stunning. And people feel shame and all kinds of emotions. Here's what I say. Tell me what you say. I say, listen, numbers are not judgments. They are observations, just like your checkbook. I may have $1. It doesn't mean I'm shamed about that. It just means I need to do something to earn some more money. So, but 51%, which is not uncommon.
It's not uncommon.
Stunning.
I'm glad you named it because people don't often want to hear it, but it's the truth and it's not an unusual starting place. I say the same thing. We work really hard on emotional neutrality and I lay that out in the book too because you have to not be so emotional about it. And traditionally, there's so much trauma and stigma with weight that you take that on. No, it's just a starting place. And what I tell my patients is they're like, well, what's my goal? And I'm like, hey, we're not talking about goal. Just like we never actually talk about like what's an ideal weight, really, actually. It's like, what are our goals for our starting place and what's achievable? And sometimes we bypass what's achievable and we go toward goal, but we're going to start with like the bite size achievements. And so that's where with the percentage of body fat, I'm like, we're just going to chip away at that. And what we're going to make sure as we're losing significant weight, that ratio improves because what I don't want is that number to go up as we lose 50 pounds, right?
Because you can be skinny fat.
Oh, yes.
Meaning more percentage fat and yet weigh less
because
you've lost so much muscle, right?
Yes. Sarcopenia. So this is something we really worry about for all patients on these meds, but really specifically over the age of 55, because it can be harder for your body to naturally hold on to its muscle mass. And we're kind of in a state of decline in those decades with muscle mass. So we really have to watch out for it. And this is not just about not eating anything. This is about being more active and building up that muscle. So how do you do it? So I will say I actually have a very soft approach to this because I do think people have so much trauma from working out. And I give people a firm deadline of you may not be on this medication for any more than 6 months or a percentage of your total body weight until we are making this your identity. But at the beginning, I let people get accustomed to the medication for a little bit of time. If they are working out, we optimize that. If they're very interested in it and motivated, we get them strength training right away. Bare minimum, I want people moving. I want them increasing their NEAT. I want them getting out. NEAT is activities just kind of like of daily living and just getting up and being more active and vivacious and not bed rotting.
Bed rotting. That's
like sitting on your phone and scrolling. No, get up, get out, get active, and start using some of the lightness that you start to feel pretty quickly on these medications and move. And then once we're really ready, and sometimes it takes some mental coaching for patients, we are getting into strength training. For some people, going out and lifting super heavy weights is not going to be the first starting place. It actually might just be getting into a physical therapist.
For most people, it is not going and lifting heavy. There's always 6 to 9 months if you're just starting out. Yeah,
exactly. And so I really identify those patients who are like, I haven't lifted anything heavy in 40 years. Well, you know what? I'm going to go get you a full body evaluation by a nice local physical therapist. And we're going to see what you need to work on first there. And then we're going to get you set up with a an age-appropriate trainer who is really going to work with you and your goals. But the transformations, people start taking those baby steps, it can be so, so profound. You just have to know it is going to be baby steps at the beginning. And then ideally, I want people really lifting heavy weights and lifting, even if it's lighter weights, to a point of fatigue so that we really work on building that muscle. And that is the thing that will just transform. And when the patients who do the absolute best on these medications are the ones who embrace diet and strength training. And they blow the traditional numbers of what we can expect on these medications out of the water.
Mm-hmm. All right. So strength training, muscle.
Ooh, bone. You want me? Oh, just quickly on bone. So bone, because this is your specialty too. So bone. There is some preclinical and early clinical evidence that GLP-1s, yet to be published on the current weight loss drugs, but we did it for liraglutide, that shows that bone reabsorption is decreased and the ratio of new bone formation on these medications is actually increased. And so the effect of these medications can actually be improved bone health. And we see that with weight loss too. You know, there is this paradox, as you said, sometimes we thought for a long time that there was some protection in excess weight, but we really don't
because
see
of the
that
hormone
anymore.
leptin. That fat adipose cells produce this hormone leptin, which interferes with bone metabolism. And so just because there's all these questions I get about, oh, I'm already heavy. Should I be wearing weighted vests? What's the deal with more weight? And so I think the missing piece is leptin. So do you think these preclinical studies that you're talking about, where you're seeing a trend towards, because I realize the data isn't complete yet,
Right.
Trends towards perhaps better bone metabolism with GLP-1s, do you think that's the effect of the hormone itself, GLP-1, or
Yes.
do you think that's because of leptin?
Yes to both. I think it's leptin. I think it's GLP-1 receptors in bone. And I also think it's reduced adiposity. So we talked about how these GLP-1 receptors are made in our body, and we have receptors everywhere, including bone.
Yeah.
And it appears that there's a positive effect by increasing the hormone that had become so quieted previously.
That's interesting because and so it all works together. People sometimes think that each organ system is doing its own little thing in its own little space. The reality is everybody's talking to everybody.
Right. I know. I think we've made that the problem in medicine because we have so many. We're just like, I just deal with the heart and I just deal with the kidneys, and then they all talk together, you know, the bones.
And what are poor patients to do, even within orthopedics? I mean, there's a knee guy, there's a hip guy. Exactly. So you got 6 orthopedic surgeons for one bot, right? I feel for patients. Sorry, guys.
I know, it's the worst.
It's the worst.
That's actually why I love what I do, because as an internist, I learned to treat all systems, but then as an obesity medicine specialist, geez, I get to positively affect every single aspect and every single specialty. So it's so fun.
So people are learning so much as they work with you. They're losing 1% of their body weight per week, so it's sustainable.
Right.
And I love that you said that you give people the expectation that in 6 months, we're either going to, it's not an automatic, we're going to do a complete reevaluation. And in 6 months, you know, if you're losing 1%, you can do a significant amount of work, but you may not be done yet. Right. So talk to this thing I read on the internet, because I'm not deep into GLP-1 research, is once it stops, you gain all the weight back. What is the post hoc?
Yes. So for the majority of people who see success on this medication, if they stop it, they will regain the weight back in its entirety.
All of it? Really?
Yeah. Well, yes. So the studies of regain go out to between 2 and 5 years, and the majority of people regain about 2/3 of their weight by 2 years. And it appears when you continue to look at that trajectory of weight regain, by 5, it'll all come back. We know that to be true.
Lifestyle, even with all the
lifestyle. Now, there are a few people who kind of have a good chance of coming down on the dose or off. I talk about this in the book. This is someone who put on weight quickly, maybe because of a medication, an illness, a life change. I saw a couple of people who just in COVID very quickly put on a lot of weight, and then they came to me and we were able to take it off and they were able to go off the medications. Those people are also really embracing diet and strength training and getting back to potentially a muscle memory and a life, a body memory that
A body
they
memory.
held. And I
Yes.
would say that the person who is more likely to get off of these medications long term is someone who did not struggle with obesity their whole life, and it was a very short term gain. So, or maybe a life like I did IVF or pregnancy. People do like, they'll come and they'll say, I gained all this weight doing this. So what
Yeah.
are we going to do?
Yeah.
So, that we have to set those expectations. And I think a lot of the conversations around this could potentially and most likely will be a medication that you need to be on for a very long time needs to be had.
But that makes sense to me based on going all the way back to the first few sentences you said to me, because you view this as a neurohormonal dysregulation that can begin at any age when we started talking about children.
Yeah.
So the way what I hear you saying, correct me if I'm wrong, is that we should think about this as just like hypothyroid. We don't think that it's a 6-month course of Synthroid. We think we've got this dysregulated thyroid and we're going to treat it forever to feel good. So what you're saying is
You,
that
you
correct?
read my mind. I was going to use that
Okay,
exact analogy because people don't
good.
have a hard time with replacing that hormone, but they
Yeah.
really have a complicated relationship with replacing the hormone that helps with our weight because we're very wrapped up in weight stigma and bias. And we really do think, for the majority of people, even if they want to think differently, we'll be like, it's about willpower. I can do it. I can do it. I can outsmart it. But for
Yeah.
the majority of people, we can't.
I don't really believe much in willpower other than maybe one day,
Yeah.
right? The rest of it's discipline and biology. Well, in the last 5 minutes, I've learned so much. I've loved this conversation. I'd like to say a few comments. I'd like you to say a few comments about specifically what happens during the zone of chaos in perimenopause when our
Yes.
estrogen's flying out the door. Sometimes she's back, sometimes she's gone. It's chaos. And then until the final time she leaves, slams the door, no more estrogen. Can you relate how you're treating people to the loss of estrogen?
Yes. So what people don't realize, well, they do realize now, thanks to people like you and Dr. Haver, they're starting to really realize it, that what happens during this time, the hormones that are affecting our weight aren't just the loss of estrogen. It also has to coincide with the rise of insulin resistance. And that's a hormone that becomes significantly dysregulated, and leptin, which you've mentioned too. So those hormones make it quite hard for our body to maintain its fat homeostasis. And there's a natural rise in insulin resistance with each decade of life, but then it really does hit women as estrogen declines. And this has to do with metabolism of estrogen and its interplay with insulin. And so these medications are a game changer in what has been traditionally expected as the natural weight gain of menopause. And I actually still see a lot of pushback in the academic societies of the obesity medicine world where people are saying, no, it's just like natural gain on par with men. And you're like, are you treating the same people that I am? No, it hits people overnight and it's so dramatic.
Yeah.
So what's very fascinating is that I have tremendous success with women in menopause and perimenopause. I do not need them to be treated with HRT. In fact, I just saw a post today. Someone was saying, oh, I feel so left out. I have breast cancer. And I just feel like I'm not getting the maximum, even in this discussion of GLP-1s. I take care of so many women post breast cancer treatment who have gained weight, are on tamoxifen. It can be a weight neutral drug for some, but for many, they gain weight. And we'll put them on GLP-1s, and it reduces future risk of cancers. And it works really well with their weight gain. So I'll say, yes. And so I will say that we don't need to be on hormone replacement therapy to see full success, but we
For
have some
metabolic
emerging
health.
for metabolic health, for metabolic health and for weight loss. But we are actually seeing that when women are treated appropriately with HRT, their GLP-1 can be even more effective.
Amazing. So there's a synergy because you're addressing multiple aspects of metabolic dysfunction in a midlife woman.
Exactly. Yes. And symptom management is so important too. I think for a long time, and actually still currently, a lot of the discussion around weight gain in menopause is like, oh, you're just not sleeping. You're just not feeling well. You're not like yourself. You're definitely eating more. Oh, listen, we know that that's not true for many people. And even if they're not feeling great, there's something larger going on. And so treating the symptoms so that you feel well optimizes what we're able to metabolically treat with both the HRT and the GLP-1. So they really do go hand in hand.
I love that. Well, Dr. Alexandra Sowa, thank you so much for teaching me today, for teaching everyone on Hot for Your Health, because you took the time today to really go back to basics, because there is so much confusion. I appreciate it. So if you guys want to do a deeper dive, get her book, The Ozempic Revolution. It's out. You can get it everywhere. And I'm thankful for your knowledge, and I'm thankful for your willing to teach us today.
Thank you so much. I appreciate you.
It's my pleasure.
Thanks for joining us on Hot for Your Health, where we bring you conversations from the bleeding edge of science, health, and culture. You can find links from today's show and connect with me at drvondawright.com. Don't forget to subscribe and leave a review wherever you listen to podcasts. I'm Dr. Vonda Wright. See you next week.